He's again a towering personality as far as the iris repair techniques go. And of course, our star performer, Dr. Iqbal I.K. Ahmed, who's known to everybody all over the world, from University of Utah, University of Toronto, Canada. Dr. Mitchell Patrick, who would be joining, who's there with us from Houston. And of course, Professor Amar Agarwal, who's the past president of IIRSI, General Secretary of IIRSI, and Chairman of Dr. Agarwal Group of Eye Hospitals. So we would begin the webinar now, and I would request the first speaker, Dr. Gaurav Luthra, to give his talk. He's going to be speaking on single pass fourth row pupilloplasty. Meanwhile, I would request Dr. Mahipal Sachdev to say a few words before we commence the webinar.
Well, good evening and good morning to all the members of this panel, and also to all the speakers. I think this is a new and innovative subject where there are a lot of pioneering techniques that have come in, wherein a lot of new interest is there as regards these techniques. And I think as Namrata rightly said, we have international speakers with us who are known very well in the Indian circumstances, as also national speakers and panelists with us from India. So I think the topic should evoke a lot of interest among all the audience and the delegates who are attending this webinar. And I think without much ado, we can straight away go into the session with the first speaker, that is Gaurav, and welcome all the delegates and all the speakers and the panelists once again to this webinar. Gaurav, you can start, please.
Thanks, Dr. Mahipal, Dr. Namrata, for the kind introduction and for helping us organize this joint webinar of the IIRSI and the AIOS today. And we are lucky to have all the stalwarts and the pioneers of different techniques. Aiki is one of my favorite pioneers and comes up with all new things, and Patrick and Dr. Amar, who's taught me so many things. I'll start with my presentation. I'll be speaking on a topic which is something that I've been enjoying for the last few years, that it was invented by Dr. Amar and described by him for the first time. And it's really made life very, very simple for us. And the applications have been amazingly growing. We'll be doing a few of these later in the program today. I'll be only showing you the basic technique of the single pass fourth row pupilloplasty. And that will then take you on to a couple of other new innovations, which Dr. Amar and a couple of other people will be describing. So I wanted to show you a few videos, and here we have this situation where there is a traumatic cataract. You can see that there is subluxation, and there is a penetrating injury somewhere at about 11 o'clock, strand of vitreous coming here. And there is, of course, an iris defect, which is not visible, with some traumatic mydriasis. So how we decided to go about this was we were planning to do a femto-assisted cataract surgery so that the subluxation does not increase. We could have easily done a regular surgery as well, but since it was possible to do a femto-assisted, and that always helps in subluxated cataracts because your lens remains more stable, and you're putting less forces on the zonules. So if you have the option of doing a femto-assisted surgery in subluxated cataracts, it's always nice. This was a softish cataract, so it was out in a jiffy. And once you have the lens in, then remains the task of repairing the iris. So the single pass fourth row pupilloplasty, which we will be utilizing here, and I'll be showing you the basic techniques and the the correct technique, and then some of the fallacies where you can go wrong, so that everybody gets a way of doing it very nicely and alertly at home, those of you who are still not doing it. So of course the cataract is out, and let me take you to the situation where we put in the lens now. And once the lens is nicely there, and then we are trying to put in pilocarpine to see if the pupil constricts, it does not. So we decide to do a single pass fourth row pupilloplasty. So this is one of my first videos. That's why you can see that I'm taking the 10-0 Prolene needle aided by a small instrument to direct it as there. But frankly, you don't need this. You don't even need an MVR entry now. You can actually just go in straight with the 10-0 Prolene needle through the cornea, because you don't really need a port there. But to come out, you can use a second needle, the 26 gauge bent needle, through a paracentesis, and then hold the iris. Now the key is to hold the iris with one of these nice forceps. You can use, I'm using the MST micrograspers, but you can use almost any good iris holding forceps which are less traumatic. The trick is to get a bite which is sufficient, and it is right at the place where you want to put in the suture. Now, sometimes you can go wrong. I'll be showing you later in this video how you can go wrong in either taking too big a bite or too small a bite. Now here we passed a railroading technique of the 10-0 Prolene passing through the iris with the 26 gauge and then out. Now all you have to do here is to pull out a loop of this 10-0 Prolene from inside using any small manipulator or a IOL dialer, and you can then get this out of the paracentesis. And once it is out of the paracentesis, you form a loop. And then the free end of the suture is passed 4 times, and you have to remember to pass it the same way each time. You pass 1 pass, and then you do a second pass in the same direction. So essentially, you are basically making 4 passes. Now, it's very, very important to do the 4 passes and not, a single pass 4 throws. So basically, this is working out as 4 throws, but you're basically making 4 kind of 4 loops over the suture and then pulling it. Now if you make 3, it is likely to get loose and it might just come off. If you make more than 4, you are just getting a thicker knot. 4 is just fine and it almost never gives way, and then you can just go in closer there. So it's like a slip knot. You just have to pull on the free ends on both the sides, and as you pull on the free ends, the knot tightens up, goes inside, and it tightens perfectly in place, and you can see you get a perfect pupil. This was another situation where we were having a traumatic mydriasis again, and I'll run faster now because you've already seen one of the videos. So here we've going in with a 26 gauge needle, holding the iris with the forceps, and then the second pass with a 26 gauge needle, railroading in and passing the 26 gauge out, and then pulling a loop out as we showed in the first one. But here we'll be doing things a little differently. We have the loop out now, and once that loop is out from the paracentesis, you pass a single pass through with 4 throws. Essentially, you're passing this 4 times through that loop in the same direction. And then you just pull on it. It's a slip knot. It goes nicely. Now you'll be wondering why I've left behind that thing, that opening there. So we will be coming back to tackle it. So we have the first knot. You can do it as many times as you want. If you have a very big pupil, you can actually do it 3 or 4 times. It doesn't take much time. It's very controlled. And here we've then cut the knot. And then I will go and pass one more suture. Again, the same technique. So I'll just rush through this. We pass it again, bring it out from the other side's paracentesis, railroad it. Then you pass a slip knot by making the 4 passes, 4 throws, and then that's the loop. And then 1 pass, second pass, third pass, and the 4th pass. And then you just pull the free end on both sides, and your knot is there. So we have a perfect knot here, but I'm not too happy about this open thing here. So this thing requires another one. So let me take you, the technique remains the same. We've managed it, and we've now managed to close it. We have a fairly good looking eye over here, and this does it. Now, showing you the animation, I borrowed this from Dr. Amar, and this really makes it very, very easy.
Proximal iris where you enter.
So once you do this, it shows you very nicely, and it makes things much more clear that you've made these from one side. We are going to pass the proximal end with the 10-0 Prolene, and that's where the 10-0 Prolene goes through. These are these iris defects or traumatic mydriasis. There are so many situations which might need it, a coloboma and a lot of other places. So that's the second one, and that's the 26 gauge from the distal iris. There we have a paracentesis in place. We pass the 10-0 Prolene, railroad it through the 26, and we come out. And I remember the time when Dr. Amar invented this, and for the first time we were sitting in Jaipur for an IIRSI meeting, and he showed me this video on his phone, and I was thrilled to see it because I'd always struggled to get these things right. And I came back, and that few days later I managed to do my first case, and it came out perfectly. So this is what you can see. There are the 4 parts of the thread now, and this is the third one, which is between the defect and then the 4th part, and then the final part over there. And all you have to do is now, basically, as we showed in the previous technique, we just pull this loop out. The animation makes it easier to understand. Just hold it. You can do it with the forceps. You can do it with a dialer or Lester's hook, and then you can, just do the same thing as we saw before. Four times you pass it through that loop which you've formed for the loop which you have pulled out. And once you've done that 4 exact times, please make sure that it's 4 times and neither less nor more. And then it works best, and you have this in place, and it works beautifully. So I think that shows it. I'll finish by showing you a small situation where we got stuck, and I'll just show this in 10-15 seconds so that you can benefit from my mistakes. This was one of the cases where one of our my colleagues was operating, and I told him to go ahead and do this for me. He wanted to learn the technique. We did a good job with the cataract, and see that big defect there. And the mistake we are making now is that we've held it too close. So what's going to happen is so here you can see I'm passing the 10-0 Prolene needle and passing it out over there. And now we are going to try and get this out the other side, holding it and getting the loop out. The problem that happened is, first, there are two problems which happened and which are basically the take-home messages. We got the loop out nicely. First thing you'll notice is as I'm going to tighten this, the pupil is going to be too small. So it's better to initially have a slightly bigger pupil forming, and then you can always come back if you think it's too small. So this is giving us almost a pinhole. Now the second problem that happened was that my needle 10-0 Prolene passed through the cornea, the lip of the wound. So now I'm stuck because I can't tighten the knot. So I'm having a situation and I'm cutting it. So anyway, these are these take-home messages from here, and I think I've already spoken enough. So I'd like to delink my presentation. I hope my message was clear, and we'll have much more coming for you after this from all the top speakers. Thank you so much.
So thank you, Gaurav, for that great presentation. And there are a lot of questions, which I think we'll take it in the end. And now I would request our second speaker, Dr. Priya Narang, who's a stalwart in the field of the iris repair. And she's going to be speaking on iridodialysis repair, two-fold and trocar assisted.
Hello, everybody.
Hello.
Thank you, Dr. Namrata.
Can I research it?
I hope my voice is clear.
Yes, your voice is clear.
Yeah.
Carry on.
So, yeah, I begin my talk with the iridodialysis repair, and I'll be covering up the two-fold and the trocar-assisted repair. So, going with this, whenever we have iridodialysis, the first thing that we actually do is, we need to assess the degree of iridodialysis that we have. So we all know iridodialysis is the disinsertion of the iris from its root. So it can be, we have broadly categorized it clinically as massive, where it might be more than 120 degrees, it might be moderate, or it might be minimal kind where, you can just get away by doing minimal intervention. So basically, when we have these categories of differentiation, which is done clinically, we decide the kind of procedure that we actually want. And actually, when we have severe traumatic cases and all, it's not just that a simple iridodialysis repair in itself would suffice. At times, you also need to reconstruct the pupil in these cases, because there is so much of damage which has already happened. So for this, basically the technique that we use is the non-oppositional repair, which has been described by Dr. Snyder et al. And for pupil reconstruction, we try to use a single pass 4-through pupilloplasty. And when we try to combine these two procedures, we call this as a two-fold technique, and we just happened to publish this in 2018. This is just a suggested reading for people who would like to go back and go through this technique clinically. So basically, now I'll just try to show you this animation. Now, when you have, this is a case where you can see there's a maximum iridodialysis here. So this is, in this case, what we'll be just trying to do with a non-oppositional repair would be, we will take a 9 or a 10. What we need is a double arm suture for this. This is just for beginners who are just trying to venture into iris repair techniques, that you need a double arm for doing an iridodialysis repair with a non-oppositional. So I'll just run through this video here. We have just taken a double arm suture, and it has passed through the periphery of the iris. Now, this is very important, that the amount of the iris tissue that you actually engage into the needle. So you need to do this through the entire circumference of where you have an iris disinsertion. Now, actually, what I'm trying to say here is that whenever you're trying to do this, often this iris tissue is, it might be fragile. So it might not be always possible for you to pass the needle from where actually you have planned to pass it. At times, you might need to take a bigger bite or a lesser bite. So depending on that, in the postoperative period, what you can get is the correctopia. That is what you are seeing here. Now, what you're seeing here is the updrawn pupil, although your iridodialysis repair has been done. So when we have cases like this, we just try to do a single pass 4-through pupilloplasty. We'll just try to close down the pupil from either side and try to get a round pupil in this. So this is what the two-fold technique actually is all about. This animation was just to explain how to go ahead with the procedure. This is a single pass 4-through. 4 throws have been taken through a single loop. You just slide it inside and then you cut it off and you get through that. So going from this to the clinical video that I'll just try to show you. This is a case of a traumatic iridodialysis, there's a maximum more than 270 degrees of iridodialysis that you see here. So you're just trying to deposit this iris tissue inside. So you can see the entire iris tissue. It's totally fragile and barely it is impossible to do this. But then with a lot of patience and grit, when you try to go ahead with this and you're trying to deposit this iris tissue out here, you know, you just create a scleral groove, try to pass through the periphery, come up and you tie it up into the scleral groove where you have done this. Now, what you see here is the irregular pupil here. There's a missing iris tissue here because this is a traumatic iridodialysis. So you do not have an iris tissue actually here in this case. So then what you try to do is that the areas where it is deficient, you try to go ahead by doing a pupilloplasty procedure. All this said and done, you have to be very careful while doing these surgical interventions because it's a fragile tissue, especially if it is a traumatic case. Secondly, what is important is to do the surgical procedure under fluid infusion because these are complicated cases. You might even choose an OVD to do that. That's not an issue, but it all depends upon the kind of trauma that the patient has had at that point of time. So as you see here, continuous repair is going on. You're trying to reconstruct a functional pupil. That is what I would try to say. It's not a cosmetic kind of thing, but it's a functional pupil that you're trying to create here, trying to give functionality of vision to the patient in the post-operative period. So that is the aim for this, how to do that. So having said and described this procedure that you see, this is the post-operative image of the case, although, if you compare this with the pre-operative image, you know, it's just wonderful because it was totally like there was no scope of getting an iris repair done in this case. So coming back to the same thing, I would go ahead with one more animation. There are different ways to build the CAD. You might initially go ahead with an iridodialysis repair and then go ahead. Now, what I'm trying to show in this animation is that you have an iridodialysis repair, okay? So what we try to do, and alternatively, if it's a minimal to moderate kind of thing, what we try to do is that first you can close down this big iris defect. So because, you know, when you will be doing a non-oppositional repair, first thing is you have to come from the opposite side and you'll try to deposit this. Maybe one, at least you might need for this amount of iridodialysis, at least 2 passes. Now, you can even close down this defect. I'll just run this animation. Sorry. I think I need to go back. Okay, so this is it. We're trying to do a single pass here. So what will happen, this iris tissue is going to come close to each other, and then, you know, you do a non-oppositional repair. So it is just that, it's just another way of doing it. So you can just bring down this area of iridodialysis by doing this. So you can go ahead with this. You can see this, the same thing in the clinical video, the animation was made accordingly. So now what you see here clinically is that you have an iridodialysis here and you're trying to do that. So just trying to cover up the peripheral iris surface, trying to just do a single pass photopupilloplasty here so that, you know, actually you decrease the area where you would be needing an iridodialysis repair. And once having done this, the advantage of doing this is that we usually adopt a single pass and doing, actually you can do any pupilloplastic procedure of your choice. There are so many of them. We try to do this because it's simple. You can wind up the surgery fast. There is minimal anterior chamber manipulation. You need not go again into the anterior chamber to achieve a knot at that particular point, for that particular point. So you might finish it off with minimal passes in the anterior chamber. So this is the same thing which I showed before in the animation, that you have done this. These are the scissors, micro scissors that go inside and you cut down the knot. And then you can go ahead with a nylon suture. This is a non-oppositional repair as described. And this is again a double arm suture which is taken up. So you just engage the periphery of the iris tissue. You have to be very careful of not engaging the corneal tissue here. This is the most essential thing. Otherwise, your loop does not slide inside. So that is one thing which I think all the surgeons need to be very careful about. And otherwise, it can lead to failure of the procedure. And you might have to just cut it off and again do that entire procedure. So this is again a combination of the single pass and the non-oppositional repair that is going on. Once the pupil reconstruction has been done thoroughly and you're satisfied with achieving the kind of functionality and the cosmetic thing that you need for the pupil, you are done through that. So this is just a repetition of what is going on. And in the end, what you try to achieve is a round pupil, which serves very well its purpose and what it is designed to be. So coming up to the main aspect of doing any pupil repair, iris repair procedure is not to imbibe the corneal tissue while sliding inside that. So for that particular reason, we try to came up with this trocar assisted handbag repair. Now, the concept is to prevent entrapment of the corneal tissue into the suture needle. And what you need in this is that you need either a 25 gauge trocar that we commonly used. We commonly use for posterior segment surgeries. You can do that, or there is a specially designed trocar anterior chamber maintainer. You can even use that. You can introduce it into the anterior chamber. Coming up to this, I'll just show you this animation, and I'll just try to show you the concept which goes behind this procedure is that, I'll just pause this here for a second. This is the trocar which is introduced inside, and it's not in the posterior chamber, but it is in the anterior chamber. The concept being that when you have placed this trocar here, you have this tunnel which is going on in, and your suture needle passes through this. So when your suture needle passes through this, there is lesser chance of imbibing of the corneal tissue. As we saw in the previous video, I think Dr. Gaurav had also showed, you have to be very careful, and he used a rod. Even I use it many times, if you have that thing, the fear of having it, of having the corneal tissue into your suture needle, you need to create a clear passage from where you can pass. So just came up with this, and this actually provides you as a leverage, as an anchorage, and you can pass your needle through this. Now, the second thing that anybody would like to tell me is that how do you get to assess the amount of iridodialysis that you'll be doing? Because like in case if you have a big iridodialysis, how do you do that with this? Because you need the leverage of this needle from this trocar. The point is that this is through the corneal incision, and you can just twist this around a little bit here and there, and then you can seal this incision with the stromal hydration that we usually do in our phacoemulsification procedures. So that's not a very big issue out here. So I think this is one tip which people can use if they're facing this difficulty, and you can see how beautifully the suture slides into its place. This is a clinical demonstration of the same thing. You take up a trocar. This is a retinal trocar. The only thing that you need to be careful about is, it has a very long blade, and you have to be very careful it does not hit into the corneal tissue. So that is something which is you have to be careful about. And for that, we have designed a specially designed trocar anterior chamber maintainer, which has a shorter tunnel, and the needle actually is also shorter, so it does not damage the corneal tissue. So now this is the clinical video. What you are seeing here, the suture, the double arm suture is sliding. The first suture has passed on. This is the second thing that is going inside, and this is the second arm. So now you can see how it slides inside. The loop goes inside, and then from your tunnel wherever you have created, it comes out, and then you can just titrate the amount of tissue that you really want to pull, and then you can from your tunnel wherever you have created, it comes out, and then you can just titrate the amount of tissue that you really want to pull, and then you can
Argentinian friends. Jurek Zavalia was the greatest Argentinian ophthalmologist, but this patient does not have glaucoma, but remember there is photomydriasis there. So I pass the needle inside, and look, from the other side is a 30 gauge needle. I've railroaded the two. Once I've railroaded the two, you can see now the loop coming out there. Once that comes out through the paracentesis, I'll bring the loop out. So once I have brought this loop out, how do I bring this out? I bring the suture to the center, go in with the forceps, and pull it out. See, that's a simpler way. You can bring it out through a dialer or something, but sometimes it can get stuck in your incision. Here you can see now, once that's done 4 times, I've done it, I will pull it and finish it. Now let's take this difficulty to the closed angle glaucoma. Because when you see Jurek Zavalia like this, you can have Jurek Zavalia without glaucoma, or you can have Jurek Zavalia with glaucoma. So that's why I wanted to cover closed angle glaucoma. But look at, in this case, pre-op, post-op. Now let's take the difficulty in a PK patient. In this patient, watch what I show you the next is the anterior segment OCT. Look at the iris. It is stuck to the cornea endothelium there. These pressures will be 30, 40, it's crazy levels. Now question is, what do? You can do a trap, you can do a valve, something like that. But what we published in the European journal was this, that with photoretinoplasty, I'm going to bring that iris down. Once I bring my pupil down, I've broken all those synechiae, and I made a closed angle into an open angle. So now you see, if you have too much of closed angle, you can do 6 points fixation. If you have less, you can do a 4-point fixation. Either way, the principle is simple. I am making my anatomy normal. That's all I'm doing. I am not making a new drainage procedure. So I've got fluid in the eye. This is a trocar AC maintainer. So in this, I've got fluid passing always through the eye. The reason again I tell you fluid is these synechiae will be there. When you break the synechiae, bleeding will happen. If you play with viscoelastic, you can always put viscoelastic in the middle anytime you want. But the fluid washes away the hyphema. Now look what I've done. I'm bringing my pupil down, doing the 4-pass through pupilloplasty, and you'll see now, once I have pulled it in, see my pupil coming down to normal size. With that coming down, my angle will open, my pressure will become normal. Look at the anterior segment OCT on your right screen, and you see not only the intraocular pressure has come down, the vision has improved, and the anterior segment OCT has drastically changed. Now look at this for retinal people. I wanted to also tell you this. It's an important thing because they have silicone oil in the eye. And a lot of retinal surgeons might be watching this webinar. Look at this. Again, the peripheral eye is stuck there. In this case, you remove the oil, the pressure will not come down. So what you do is you refer it to a glaucoma surgeon for something. But instead, if you just do this procedure where you can see the preoperative and the post-op picture, anterior segment OCT, and you can see how different the game is. Finally, what I want to tell you all is that we are also having this new book of hours which is coming out. I don't know if you are getting the image on the screen there. Are you seeing that?
No.
We are not seeing it.
No.
Oh, it's not coming. Why is it not coming then?
Bolo.
Oh, I have to again stop and start again.
Stop and share it.
Okay, and then share screen. First on the thing. Now, 1 minute. Now it's okay. Are you seeing it now?
Yeah, it's coming.
Okay, this is the new book which is just coming out by us in September, which will be coming out by Slack. And I thought I'll show you one more thing is which Namrata will talk to you about later on, is on the Ophthalmic Premier League, which is there on Tuesday, which will be telecast at 6:30, which will be an international webinar on a very interesting thing of International Ophthalmic Premier League. Thank you very much.
Thank you, Amar, for those very complex cases in which you did iridodialysis repair and also did a pupilloplasty for single pass 4-throw pupilloplasty to not only correct issues of the iris but also the issues of the cornea. And I'm going to be inviting the next speaker, who's Dr. Ashwin Agarwal. And again, he's going to be dealing with a very complex situation, and that is iris repair in complicated conditions. So Ashwin, can you share your screen?
Yes, I will. Hi all, I hope you're able to see my screen.
Yes.
I'm starting the play. If you can see it play, let me know. Is it playing?
It's playing.
Okay, so is it full screen?
Yes.
Okay, perfect. So I wanted to share with you some of the complicated cases, and I think this was a knifing injury which a patient had come to me with, and I thought it's very important to show you guys how to deal with such scenarios, in which steps or what is the methodology involved in it. So let's just start with pretty much what I did in this case. This was a bad trauma where I have just 3 points of attachment, one on top, a broader based attachment on top, a smaller inferior attachment, and one which is attached into the corneal wound itself. Now there are two choices here. One is to do a PK itself, or I can first repair the iris, first put an IOL in place. The cataractous lens was removed in the primary surgery itself. So let's start dealing with the complex scenario of actually dealing with the IOL. In order to deal with the IOL issue over here, I'm using a glued IOL technique over here. I've made my flaps and I'm avoiding most of the steps over here. I'm putting an iris hook in place because I need to see visualization. Just the central 3 millimeters is enough for me. If I get that, I am placing my lens, externalized one haptic with the handshake technique. And if you see, I'm not actually holding the second haptic. This was a trick taught by Dr. Priya Narang itself. No assistant glued IOL. And now I'm basically externalizing both the haptics. I have now been able to tuck my haptic into the Gabor-Chariot's tunnel. Once this is done, now I have to tackle my iris repair. Now, as I think Dr. Abhay said it very nicely, if you shouldn't try it if you cannot manage it, but in this case, the patient was a very non-affording one, and I didn't have a choice but to go ahead and try at least and repair whatever I could. And hence, doing a hangback technique over here, was the first option. So hang back technique, both double arm Prolene suture taken, making a scleral ridge, going on one side and pulling it apart, ensuring that I'm securing that knot into the scleral ridge over there. Making a second ridge because that counter traction over here will help me doing a pupilloplasty at the end. Now this was a very important step over here, which a lot of us might miss. Now if I did this without doing the second hand back, I would actually lose this traction which I would have had. So first I'm doing a hang back, and now do a pupilloplasty repair. The second one, my heart was in my mouth, but I still had to proceed ahead and go ahead and try and attempt to close that gaping optic which I could see of the IOL. And fortunately for me, in this case, I was lucky to get away with this. I did not have to do a PK at that point of time. Probably in the next 1-2 years, I'm going to follow up this patient and see if we need to do a penetrating keratoplasty. This was the post-op 1 week of the same case. Vision improved drastically and was very, very happy. I'll show you another case which explains a little bit more on the methodology that I use pretty much in these traumatic conditions. I hope is it visible?
Yes, it is.
Okay, sorry. Okay, so this case basically had a corneal tear, sphincter tear, there was a iris stromal tear and an iridodialysis. Along with that, there also was a traumatic cataract and an anterior posterior capsule that was torn. I'm not, in interest of time, I'm not going to show you the cataractus part. I'm going to dive in, just going to show you steps, what probably were involved. The cataract, the capsule was broken over here. So I basically did whatever I could with the capsule and removed it. Fortunately, there was very soft cataract over there, and that came out very easily. But the posterior capsule itself was broken, and hence I had to, and the sheen of the bag, if you see the sheen of the bag, it was not very good to place an intraocular lens in any case. So I actually went ahead and did an anterior vitrectomy in this case from using the trocars, the trocar only for the infusion, but using the gludial sclerotomies for my anterior vitrectomy. Now I'm placing my lens in this case, externalizing both the haptics, just like how I did in the previous case, because I have my central 3 millimeters of pupil open. I'm not really worried about the iris at this point of time, but now I really have to, as Dr. Priya said, you have to sit and analyze these situations as and when you're doing them. So now what do we have here? What are the steps that could be involved? I cannot do a hang back first in this case because I don't know where to do the hang back, because I have a pupil tear. I also have an iridodialysis. I also have an iris stromal tear. So there's a full cut over there along with an iridodialysis. So what I really am doing is first attaching my root. If I have my root in place, then I can attach the hang back or I can attach an iridodialysis. So first, this is not the leaf of the pupil, this is the leaflet of the root of that iris. So now I'm doing a single pass 4th row for the root of the iris is what I'm trying to do here. If you see, methodically what I'm trying to do is first attach the root. Once my root is attached, sit and analyze the situation again, because you don't know where you're going to be able to make that iridodialysis repair. You also have a 5 clock hour iridodialysis. I'm using my glue dial to do my hand back. I don't really need a ridge. I don't need a tunnel or anything like that. I'm using the base of that flap itself to actually do my hand back technique over here. Now again, 2 Prolene sutures through a corneal wound on the opposite side, a paracentesis. You can use a trocar as Dr. Amar and Dr. Priya had described before. And once we are done with this, we basically cover that suture knot with the flap. But is this case over? I feel that that optic was actually disturbing me at many levels. So I really went back ahead because these pupil leaflets were actually still left aside. And the methodology here is step 1, step 2, step 3 were very different in each of the cases. What I really want to show you guys is the method may be different, but the approach has to be that you really need to sit and analyze each of these cases one by one before you go and solve them. The idea here is basically, now you see the end of this case. This is post-op day 1. I want to show you the post-op day 3, and here is a 3-week post-op. The patient was exceptionally well, was 20/30 vision. I wanted to show you one last case which was very, very a sewing machine technique which was taught earlier by Dr. Ravi Kumar. I hope my screen is clear and visible. The video is playing.
Yes.
Yes, yes.
So here is an iridodialysis. The case basically came to me with a phaco wound of the root of the iris that was through the phaco that just dragged the iris, and many times it happens. It can happen to any one of us as well. So there's a cataractous lens inside. But first things first, I know that there is an iridodialysis there. I'm making a scleral ridge on one side, and I'm first ensuring that my cataract comes out. This was a younger patient, so I didn't have to actually use high power or anything like that. I used my normal technique, just place an iris hook in place so that the iris doesn't come in the phaco probe. That's the only trick I will tell you for removing the cataractous lens if you don't have a posterior capsule or the anterior capsule rupture. If you don't have any of the bag related complications, then just go ahead and place your lens in place. Now start attacking the pupil repair. So first, once you get this in place, now let me talk about the apparatus. Now first I'm just releasing that to ensure that that's where the iridodialysis. The apparatus that I use here is a 26 gauge needle and a ninoprolene. I thread the ninoprolene through the 26 gauge needle and pass it all the way through. And now I use the opposite side paracentesis. I'm showing this through an animation. If you can see this very clearly, go through the iris root, come out through the scleral ridge. If you want to make a pocket, that's fine. It's all are fine with me. Go out, don't come out of the eye, just go again through the iris root and come out and make a loop. Make a second loop as much as required in every case, as much as you want. Now cut between the loops and remove the excess sutures that you don't need. Tie suture 1 to 2, 3 to 4. As you can see over here, 1 to 2 is tied down and 3 to 4. Now there are other versions of the same technique where you can pass it through and through, and I can show you those on a separate chat, but right now just for the viewing of this, I think it's easier to understand it over here how the sewing machine technique works. This is a live case, that's the free end. Now you get a loop and then you pass it again through the iris and come out through the scleral ridge to give you a second loop. Once you have these two loops in place, this is how it will look. Your free end and two loops, you cut in between the loops. You cut in between the loops to get this pattern, and now you go crisscross. So you basically are crisscrossing 1 to 2, 3 to 4. Again, I'll show this in an animation, so you don't worry. Even if you're not able to see the sutures very clearly over here, the animation picture kind of explains it. And here you are, the crisscross pattern. And that's pretty much the end of the case, because now you have a suture that's tied down. You can do your irrigation aspiration, glue this down into place, and that's the end of the case for this iridodialysis repair. Here are some of the animated pictures that help explanation. Thank you very much all. Thank you, Dr. Namrata, for having me, and everybody on the panel. Thank you.
Thank you, Ashwin. Those were really complex cases which you dealt with.
Thank you, Ashwin. I think there are a couple of questions. We'll have just one or two questions. Dr. Suhas, the panelist, would you like to say regarding this particular technique, do you think if you're doing a pinhole pupilloplasty, would you want to implant a trifocal or a multifocal lens in these cases? You
have to unmute yourself. Unmute. Admin, can you unmute? Yeah.
No, it's muted. Suhas, it is muted.
Yeah, it was unmuted actually.
Yeah.
Now, what I want to say is, now pupilloplasty is a situation that will come for extreme cases. And if I'm putting a trifocal, obviously, to my knowledge, trifocal and pinhole probably will not go together.
So Amar, you were saying that it increases the depth of focus. Really, does it also give some reading ability to the patient if you've done a pinhole pupil? Because if the person has a pinhole, he should have a depth of focus, right?
That's correct, Maipal. What happens in these patients is they're able to see distance and near without glasses. So even if a patient is, let's say, 55 or 60 years of age, the advantage is you don't need a trifocal, as Suhas very correctly said, or you don't even need a multifocal. So if you are already putting a monofocal into that patient or a toric IOL simple into the patient, the pinhole pupilloplasty 1.5 millimeter helps this very well. One issue which many people have been asking, and Namrata was telling me people are asking, is what about fundus examination? If you do fourth row pupillasty, the pupil dilates a little bit, so you can see the central fundus, etc. You will still be able to see the fundus, perhaps not too much of the periphery. But let's take a worst case scenario. After 5 years, patient comes to you with a retinal detachment or some problem like that. What do? Very simple. All you do is take a YAG laser and shoot, and you're back to square one, and you'll be able to see it. These patients with high astigmatism are actually very badly blind. The maximum astigmatism I have corrected with this is 26 diopters. So you can imagine a patient with 26 diopters will be practically blind, just seeing counting fingers, and they start seeing 6, 18 immediately.
Yeah, so actually, Priya, maybe you can pitch in the question. This is a question that everybody asks regarding the pupil. So a patient will come to you with a retinal detachment, but that's when the macula is involved. In case a patient had some symptoms of flashes and floater, you're not going to do a YAG, I suppose, to cut the suture and look at the periphery of the retina. So under those circumstances, you would obviously miss early lesions, which are peripheral, which under normal circumstances, one would have been able to pick up. And the second thing is that does it give you a good cosmetic kind of an appearance? Because a person, if he has irregular astigmatism, and maybe if you do a DALC or some kind of a corneal procedure to remove the irregular astigmatism, won't that be more acceptable to the patient rather than doing a pinhole pupilloplasty and obscuring the indirect ophthalmoscopy for a normal day-to-day purpose?
I think coming up to the first point that you said about the peripheral lesions, I do agree if the patient is symptomatic and if the patient has some retinal issues and the periphery has to be examined. If there is a difficulty in examination, then obviously we need to get away with that suture, and you need to do it because posterior segment involvement is also there. Coming up to the second point of pinhole pupilloplasty, I would suggest the depth of focus that is achieved with pinhole pupilloplasty is simply amazing. That has been studied with the clinical trial sweep machine, and it ranges from plus 2.5 to minus 2.5. And the outcomes that have come up with PPP are too good. So I think that doing a pinhole pupilloplasty, I would recommend doing it because the depth of focus that you get is amazing. Even if you pick up some of the cases for DALC or what other corneal procedures that you are seeing to replace the tissues, but if the central area of the cornea is clear, I think PPP doing a pinhole pupilloplasty does make all the sense because you get all the benefits. Even you get an amazing near vision, intermediate, and a distance vision also.
Maipal, can I comment?
Sure, Abhay. Yeah.
I think the advantage the pinhole will be that it's in a sort of a reversible way. If you do a corneal procedure, it's not reversible. So I think the pinhole has an advantage over other permanent kind of procedure. You can always go back and revert back if you need to.
No.
I agree to that.
The of the procedure is not required if there's a corneal problem. The irregular astigmatism is because of a corneal problem. So if you are replacing the cornea, there is no reversibility that you really required for that. And another question that has come is that if you have to make a pupil pinhole, would pilocarpine also do the same? That's a question.
Or can that be used as a test, to tell pre-operatively only?
What you can do is, with a pinhole, see, for example, these patients sometimes are dilated or fixed pupils. So even if you put a pilocarpine, sometimes it will not come down, like I showed you in many of those cases, which I showed you on the videos on. So instead of that, with Epsilon Martin group and through Jack Holliday's idea, we have made now pinholes of different apertures. So what you do is, you can put a pinhole in front of the patient. Everybody in their hospital clinic has the pinholes. Give a pinhole, show the patient how they will feel without it and with it, and they'll see a huge difference. So that is how will give you an indication. It will help. Coming to the question which Maipal, one of the delegates, had asked is, if I was to do a DALC, let's say there's no scarring, there's astigmatism, and I want to do a DALC. I have seen even with best hands, even post DALC, you have astigmatism problems coming up. So let's be real there. In this, there's no problem. Here I see the patient in the morning when I see the patient by afternoon or even the next day, the patient will start reading 612 to 69. So there are big advantages of it. What is the cost is just one suture. You're not spending on an IOL which has got FDA problems. I'm talking of the pinhole IOLs or of piggybacks. So that's the second big advantage.
Okay. I think we'll come to the next talk now, and the next talk is by Dr. Iqbal I.K. Ahmed. I think we all are waiting for his talk, and he's going to be talking about circlage pupil repair.
Thank you very much. It's good to be here. It's Comet. I'm with you from Toronto. Let me see if I can get my slides to show here. It's an honor to be here. I want to say hi to everybody in India, as well as around the world that's attending this meeting. We've been in quarantine, like many of you as well, and this is an opportunity for us to share and to enjoy each other's company. And it's been great to hear everybody here as well. I want to thank Ashwin and others, and Amar and others who invited me here today to be a part of this group. It's an honor to be here as far as being with AIOS and also with IIRSI as well. I've been to India once, although my heritage is from India. So, Hamara Urdu Thora Baat Kar Sakta? That was from Mitch. I hope you understood that. But I'll be speaking in English here. I'll be speaking about cerclage here. Often, sometimes what is missed when we talk about iris suturing and pupil repairs is what our hand positions are doing. And the holding and the grasping of the instruments and the twisting and the turning and the flexing of our fingers really help to ensure that, for example, the needle pass glides freely and avoids traction to the iris. So pay attention. I'm just showing this GoPro video just to show the positions of my hands on a patient's eye. And when we're tying sutures, for example, you'll see that the instrumentation, in order to place through incisions, should be done in a manner that minimizes torquing of the eye and maximizes the fulcrum ability of that incision, and therefore holding instruments in a very flat position is advisable, as you see, for example, in this video. So I just wanted to show that brief little tip just to talk about hand position, arm position, and the incisions management as far as the microinstrumentation. I also like to plan my surgeries by thinking about my incisions. This is the case, for example, where I'll be planning on placing a couple of iris prosthesis in the bag for some sectoral loss of iris, as well as suturing the iris. And I've planned my incisions considering the long nature of that needle. It is also helpful to have the right instrumentation. We've heard this already. Many years ago, before people were really doing any iris repairs, I found there's a lack of availability of instrumentation, and we tried to design instruments that would help to hold the iris or to hold sutures. And we differentiated micro graspers from micro tires. So these are different aspects that can be used in terms of managing these difficult cases. Let me make sure I'm muted here. In terms of instrumentation like this, micro time forceps can be used in different ways. Sorry, I hope I'm still okay here.
You're fine.
And I'm going to show a technique here called the Mikami Technique. Hopefully, can you hear me okay, Ashwin? Are we okay?
Yeah, you're good. You're good. There was
I thought I was just talking to myself for a few minutes there. What we're using basically here is a suturing technique. We're using a micro grasper to grab the iris. We are coming out of the incision, taking a Kuglen hook to bring the suture out of the incision. So now we have two ends out of the eye. Very similar to what we've seen with the steep sliding knot and the four-throw pupiloplasties we saw earlier. Here we're using the micro tire to actually suture around the short end of the suture, long end of the suture, grabbing the short end, just like we would outside the eye, and then pushing it into the eye. This is a very reproducible, easy technique to use. There's no worry about looping the sutures and moving the sutures in and out. It's simply just looping on the sutures very quickly and pushing it into the eye, very, very straightforward. And then cinching it down, and whether you do a 4-pass or whether you like to do a locking suture, this can be done. This patient here came to me, had a traumatic cataract, an atonic pupil, was wearing multifocal contact lenses, and was very keen on getting her cataract out, as well as maximizing her depth of focus. In this case, we took the cataract out fairly uneventfully. We put a CTR in. We put a pupil independent diffractive bifocal lens here, in this case, into the capsular bag. And then we evacuated the viscoelastic, because as you know, we're going to be doing a cerclage here. And we moved the center of the lens to approximate the visual axis by utilizing the first Purkinje image. And therefore, you can see the lens is moved a bit nasally here. For the cerclage technique, it's helpful to ensure the iris is fairly mobile and not sneaked down. And the iris may be a little bit atrophic. However, as long as there's tissue available, we can typically move forward with doing the cerclage. What I want to note here is I've made 4 incisions to do the cerclage, well, the main incision and 3 other incisions. And I'd like to note that the forceps here are being used to do the work. The needle is held in the anterior chamber, moves forward slightly, while the forceps is actually bringing the iris to the needle tip. And then emerging from the eye very carefully using a docking approach with a cannula to avoid entrapment of the needle in the cornea. It's very helpful to be a bimanual surgeon. Here we're using our left hand to grab the needle, the right hand using the micrograsper, and this is a basting suture technique where basically we're rolling the needle around the iris tissue. This creates a more round pupil, and for me it's very important to get the pupil as cosmetically pleasing as possible. I realize sometimes it's difficult when we have missing iris. These cerclage techniques are helpful when there is uniform atonicity of the pupil and there is no specific focal iris defect. If there is, then using a more localized technique with interrupted multiple sutures may be more advisable, or what we call a partial iris cerclage may be done. Here now we've emerging through the main incision. We're going to now show the Mikami technique that I showed earlier, where we're using a mechanical style suturing outside the eye, but rather than bringing the iris to the incision, we're pushing the knot in. This is perhaps one of the easier suture techniques to do, and it allows us to titrate the tension on the pupil and the iris suture quite exquisitely. We can place a micro tire through another incision as well. And I like to adjust the pupil size to about 3.5 millimeters in size. Now we'll lock the suture. I have to say, I like to lock the suture. It takes me another 10 seconds to lock the suture, but it really helps me to ensure that that knot will be present and still. And 3.5 millimeters does allow good peripheral retinal visualization with scleral indentation or a wide field contactless viewing system in the OR. And there's our pupil present there, and we can see the pre and post as well. Now there are conditions like this where we have to consider we also have an iridiolysis present as well. And these conditions can also be done and managed with a cerclage suture. Priya very nicely showed various iridiolysis approaches. You can see this is just a little less than 90 degrees in its size, just under 3 clock hours. In this case, I should mention this needle I'm using is a straight needle. I prefer to do a straight needle for dialysis repairs, going across the AC, going through the sclera just behind the blue zone and the white zone here, as you see present. And I'm using a docking technique here to dock the needle. This is an STC6 Ethicon needle, which docks nicely with a 27 gauge hypodermic needle. Double arm suture, again, going through the same incision. In this case, I was able to place 1 mattress suture. Keep in mind where the suture is exiting, because it does help us to exit over a larger arc length on the outside of the eye than when we enter inside the eye, because we have a larger circumference, and therefore it stretches the iris out. We then tie the suture, and I'm going to do a slip knot here because we know we still have to manage the pupil here, and the slip knot allows us to titrate the tension, because the concern is here after we do the cerclage, we may loosen the suture or it may break. So in this case, we just did a slip knot. Now here we're going to do the cerclage technique again. I like to start nasally, and this is a CIF4 curved needle from Ethicon, is what I use. This needle allows us to pass through the AC and come out through the cornea easily, and its taper cut is nice to place through the pupil as opposed to the spatula. And we are now rolling the suture again in a basting style technique to basically create more of a rolling suture. I should mention this is more of a rolling suture rather than the basting technique. Basting will be in and out. This is rolling. The rolling approach allows us to create a nice round pupil. So again, we're just going to go we're going to divide up the pupil in 4 quadrants. We have done the infranasal. Supranasal is going to be done now. We come out of the eye, and then we go back in again to do the supratemporal and the supranasal, the infratemporal, and now we have a complete purse string suture. Iris cerclage and pupil cerclage to me is one of the most elegant but perhaps taxing techniques. It requires us to optimize closed system techniques, as well as respecting the nature of the fulcrum in managing instrumentation through small incisions. We are now using, again, the Mikami Technique, which is basically, again, tying outside the eye and pushing it in. And we'll titrate the tension carefully to, again, get the right pupil size. And once we're happy with that, we'll lock the knot, as we said, simply to basically do a reverse throw, lock it in, and then we will lock our iridodialysis suture to ensure that we have tension that's achieved and rotate on into the eye. And then there's our post-operative appearance, and we have a fairly reasonable round pupil. One last thing I'm going to mention is that cases like this are not amenable to iris cerclage. And these patients require us to also reposition the pupil. We do multiple sutures here to close the defect. But what I like to do is I like to use an endodiathermy. In this case, it's a 23 gauge cautery, bipolar cautery attached to my phaco machine. And by the way, I'm just showing here an intraocular tying suturing technique. You can also use the microtires inside the suture as well. And we're going to use the cautery here to move the pupil. This is incredible. This is really a great way to reshape the pupil, make it round again. When you have finished your pupilloplasty and the pupil looks straight at an edge, take the small cautery and round it out. This will create, again, a more cosmetic, pleasing pupil, which I think to our patients is very important. And you can see we just closed that defect, but you'll notice that there's still a bit of a straight edge present on the temporal side. And after I lock the knot, I'm going to place a little bit of cautery just in the area temporally, as you'll see here, to create a nice round pupil. So that's one option you can do. We're trying to recreate the pupil, and we've been able to do a lot of different manipulation in this as well to see the pre and post-operative picture. So those are my slides. I want to thank everybody. We'll see you around at more and more webinars. We've probably been seeing each other more than we normally do, but I look forward to the day we can actually see each other in person and give each other a hug and high five. Thank you very much.
Thank you so much, Dr. I.K. Ahmed. And again, there are a lot of questions which we will take in the end. And the last talk of the day is Artificial Iris by Dr. Mitchell Patrick from Houston.
All right, well, thank you, everybody. Let me get my window up here. All right, how am I doing?
Great, you're on.
Perfect, perfect.
Okay, great. So I'm going to talk about artificial iris because at least in the United States, we finally have an option for this. I'd like to thank Dr. Sharma as well as Ashwin and Amar for inviting me to participate. And actually, one thing I learned today is that I've been to India as many times as Ike. I never would have thought that, but I was lucky enough to be there this past January for the IIRSI winter meeting, and that was a great time. So I look forward to my next option to travel there. So for us in the States, you know, life isn't fair because we don't really have a lot of options for repairing or putting in implants to repair iris defects. You know, both Optec and Morture make iris segments that can be implanted into the capsular bag. And we used to have access to the Optec IOL that was a, you know, sutured IOL that had a iris aperture in combination with the IOL, but that we lost access to that several years ago. You know, but finally we've recently received access to this custom flex artificial iris, which is produced by Human Optics. And it's indicated for the treatment of total or partial aniridia in adults or children. And that can be from multiple causes, congenital aniridia, but traumatic defects, et cetera. So, you know, I think a lot of us by now have seen this device, but it's a silicone elastomer and it's got embedded pigments in it. You can either fold it to or inject it into the eye. It comes in two models. One model is just the silicone elastomer without any meshwork, but the other model has an embedded polyester meshwork, which you can kind of see there in the middle of the cross section of one of these implants. The nice thing about this is they're all custom matched to individual patients. So if you've got a patient with a unilateral aniridia, we'll take photographs of the fellow eye, and then that will be custom matched. So they'll produce an implant that is really individualized for that patient. If you've got a patient with bilateral aniridia, then they can actually choose their eye color. So they can pick whatever design they want, and they'll make the implant to match that. Since they're all individually created, there's a fair lead time on this. It takes anywhere from 2 to 3 months to get one of these implants. They can be put in the capsule or in the sulcus. If you put them in the capsule or in the sulcus passively, meaning you just set it in front of an IOL that's in the eye, you don't need that meshwork within the implant. If you're going to place it in the sulcus and use sutures to fixate it, or actually fixate it to an IOL and then fixate the IOL to the eye, then you need that polyester meshwork to provide a little extra support for the sutures that might be passing through the implant. If you're going to inject it, you can actually do this through a 2.75 millimeter incision, so it can go through a small incision. You need it to be a little bit larger opening if you're going to insert it with forceps, and you can usually get that in through a 4 millimeter incision. So if you're going to fixate it inside the capsule, you need a capsulorhexis that's not super large, but it has to be at least 5 to 6 millimeters. A little bit towards 6 is going to be a little bit easier. The smaller, it's going to be a little bit tougher to get in, but you got to be careful. You don't want your rhexis too big. Sure, it'll make it easy to get it inside the eye, but over time, as that capsule contracts, the prosthesis can actually be squeezed out of the capsule, so you have to be careful with that. When you're implanting this, you're going to use trypan blue to stain the capsule so you can visualize it. One, to help you make your rhexis, but two, after, say, you're doing this in combination with phaco, when you're done with your removing the cataract and implanting the IOL, when you're getting ready to put this in the eye, you're going to want to restain your capsules to help with visualization. The one thing you got to be careful for is in congenital aniridia. The capsules are known to be a little bit more fragile, and we know that trypan blue can actually make the capsule more fragile. So for those cases, we want to use ICG to stain the capsule. Sizing is pretty critical no matter where you put these in the eye. And when you're putting them in the capsule, if you're doing an adult eye, 10 millimeters seems to be a good size. The prosthesis actually comes larger than that, so you can tree-fine it down to the appropriate size. If you've got a larger eye, like a high myope, you want to increase the size of the prosthesis, so about 11.5 millimeters is a good idea. You can do a UBM to maybe size the capsule, which might help you judge how big you want to make this. And then in a pediatric eye, you want it to be a little bit smaller, about 8 millimeters. But if you size it too small, it can slide around in the capsule. You can end up with a decentered pupil. So you have to be a little bit careful with that. You always want to put in a CTR, because as I alluded to earlier, if the capsule contracts, these can shift and be extruded into the anterior chamber. So you always want to put in a CTR. And then because you're putting an extra device in the capsule in front of the IOL that you implant, you want to target about 3/4 to 1 diopter of more myopia than you want to end up with your refraction. So this is a video that I'm going to show. This is a patient who has 16 cut RK. So he's got an irregular cornea. He also, you can see, has had a traumatic traumatic iris defect here, as well as a dilated pupil. So this patient elected to go with cataract removal as well as implant of this device. So you can see we have a 5 to 6 millimeter rhexis. We're dialing in the CTR here. We just do this manually. We could use an injector as well. So we're restaining the capsule so we can better visualize it when we insert the implant. We're removing that with viscoelastic. Refill with more viscoelastic. The more viscoelastic, the better. So we're injecting this in, so you can see we can do this through a 2.75 millimeter incision. This is one without meshwork. It takes a little bit of effort to get this open. We're going to massage it with a second instrument. And what we'll often need to do, or what we really need to do in each case, is come in with forceps. And we're going to use forceps to pull it toward the center and actually twist the forceps to decrease the diameter 90 degrees to the axis that we're trying to implant it. And it can require multiple iterations here to get this in, and you're using a second instrument to try to slip it under the capsule edge. And these techniques were developed by a lot of different people. Mike Snyder's been a big lead in this, as well as Kevin Miller. Ike's done a lot of work with these too. And they've kind of helped us learn what the best techniques are to implant these. As you can see there, this patient has some ability to constrict his pupil. So I injected a little myostat at the end to constrict the pupil because I want to make sure that there aren't certain sectors that might constrict more and actually cross over into the aperture of the implant itself. And I did a few little sphincters or sphincterotomies there to prevent the iris from constricting a little too much. If you've got an atrophic iris and it's changing the color, and which might contrast pretty highly against the implant that's behind it, you can actually remove some iris with a vitrector. It's good to leave a little bit of iris all the way around peripherally, especially with sulcus implantation, which I'll talk about next. But you can, take your time and gauge how much iris you're going to remove to get your best cosmetic appearance. If you're going to put these in the sulcus, again, as I just alluded to, it's really good to have a 360 degrees of residual iris if you're going to put it in passively, and you're just going to set it in front of the IOL. When you size these, you want to measure the sulcus diameter with an intraocular ruler. MST makes one of those. I think it's a Mike Snyder design. You'll see that in my next video. And you want to trephine or make the implant about a ½ millimeter smaller than the size of the sulcus diameter. So you're going to suture at least one edge, 1 millimeter from the edge of the capsule. Sorry, I got a little visitor there. And you want to pass the suture at least 1 millimeter edge or from the edge of the implant. You got to be careful if you're doing passive fixation. You can get micro movement, which can give you UGG syndrome. So you really want to. Haven't really employed that myself. So if you're going to suture the implant, Gore-Tex works really well. I think I favor Gore-Tex these days for most suturing of anything under a little bit of stress. But with all Gore-Tex usage, you really want to, these days, I think we avoid Hoffman pockets. And again, leaving a little bit of native iris tissue helps to keep the implant from prolapsing into the anterior chamber. So even if you resect a little bit after you implant it, it's good to have some in there if possible. So this is a video courtesy of Doug Koch. You can see here, this is implanted with an IOL. So we've got a sutured CZ70BD IOL here. So we've got a large incision to start out with to get that IOL in. So we don't have to necessarily stress as much about getting this through a small incision. So we're going to pass our Gore-Tex suture through the same paracenteses that we used to implant the IOL. And here we can just fold it in half. If we're going to put it through a smaller incision and fold it in the eye, we're typically going to fold it into thirds. Once we get it in there, we're going to sweep it with a Sinskey hook or a second instrument and take our time unfolding this, making sure to get it under the peripheral residual iris tissue here. And then we're going to pass our Gore-Tex sutures again out through these paracenteses and tie it again. And we can rotate our suture here. Now you can see there's a little bit of residual iris there that's a little bit darker. Probably that won't be that much, that won't be that noticeable cosmetically, but you could remove a little bit of that if you want to with a vitrector to get a little bit more peripheral. I'm going to finish up talking about fixating the implant directly to the iris and then, to the IOL, and then suturing the IOL in place in the eye. Again, since you're using sutures with this and you want to make sure you use the prosthesis that has the mesh embedded, the sizing's the same. You want to trephine at a ½ millimeter less than the measured sulcus diameter. In the USA FDA study, the implant was sutured to the IOL haptics, and then the IOL haptics were sutured in place in the eye. But you can also use belt loops, and that's what I'm going to show in the next case. I've seen videos that Ike's put out there also using belt loops. And to me, this is a nice way of putting the implant or attaching the implant, the IOL, to the iris prosthesis. So a larger incision sometimes is required, and then you can actually fixate the haptics, again, either directly to the implant like I'm going to show here, or if you're suturing the prosthesis to the IOL, then you can fixate the IOL also with interscleral techniques such as glued IOL or Yamane. Those can be a little bit more challenging because when that implant is sutured to the IOL, it decreases your visualization a bit. So this is a case of a traumatic open globe injury that was repaired elsewhere. And you can see they got a good repair of the cornea, lots of sutures around the cornea, a lot of scarring here. And you can see some underneath there, especially inferiorly, we've lost a lot of iris architecture. So we're going to do a PK here. So we're going to implant this open sky. So we're going to have a very large opening with which to do it. First, we'll do a little bit of cleanup, which I'm not going to show too much of, but we can see here we've got our Flöhringer ring in place. We did a temporary keratoprosthesis so our retina colleagues could do a good vitrectomy. We're measuring with this ruler to measure the sulcus diameter. We're going to trephine a 0.5 millimeter less. Here I'm doing this by hand, but they make nice devices to make sure you're centered with your trephination. Here I did belt loops where I made the incisions perpendicular to the edge of the implant. You can see we've tucked the haptics through those little belt loops there. And now I'm going to go 90 degrees and make my marks to pass my Gore-Tex suture, again about 1 millimeter from the edge of the iris prosthesis. Since it's open sky, this is actually pretty easy. We're just going in through 4 paracenteses we've made here, and we're going to insert the combination of the IOL. You can see the haptic passing through the prosthesis there. We're going to tie slip knots here. I'm not going to tie this fully because my eye's open and I'm not sure of my tension here, but I'm just going to make a slip knot to anchor it in place, and we're going to save that for later. I'm going to proceed with my PK here. And once I get my PK in place and the eye is, the pressure's increased, then I'm going to tie off my sutures, get the appropriate tension, and I can rotate those Gore-Tex knots. We don't want to leave any Gore-Tex knot on the surface of the eye. And again, Hoffman pockets are good to be avoided with this. So here we can see our before, and this is afterward, after our sutures have been removed. Patient had a really good cosmetic result. Unfortunately, they also had a traumatic macular scar, so their vision had improved, but it's still not as good as we would have liked. But the patient was really happy with this outcome. So, you know, we've got multiple options for iris replacement outside of the US, but this is our really only option inside the US at this time. It's really actually a great device. It's very nice that they can custom color it to match the patient's fellow eye. You've got several options for putting it in the eye inside the capsule, the sulcus, which you can leave passively or suture it, and then you can attach it to the IOL as well. But it is expensive since it is custom. In the US, it costs about $8,000 per patient. Insurance coverage is improving, but it's still a hurdle we have to overcome. So with this said, I'll end. I'll thank you for your attention.
So thank you so much, Dr. Mitchell, for that lovely presentation. And I think there are a lot of questions. We have been watched by 4,000 plus people on the Facebook, on the YouTube, as well as on the web browser. And there are 160 plus questions or comments and lots of congratulatory messages from all over the globe. And I think we'll start the questions. So some of them are very simple ones, like for Dr. IK, there's a question which says that is your encerclage also reversible, just like single pass for pupilloplasty is?
Yeah, I think like you heard earlier, it is. You can laser that suture if you need to, or cut it, so it can be reversible. I haven't had to do anything yet for any of my patients that I know of so far, but it can be done. I think keeping it 3.5 millimeters, I think allows us. I mean, I hear the biggest concern, people who don't do this, you've heard it already, they're paranoid about peripheral retinal visualization. Mitch gave an absolutely beautiful presentation on the human optics prosthesis, and that pupil size is, you know, around the same range there, 3.35 millimeters, I believe. So, you know, our retinal surgeons haven't had a problem, to be honest with you. And slow depression, as I said, and wide field viewing is enough, and it's not usually needed.
So there's another question, Ike, for you, which says that how many passes do you take in a given, how many bites do you take in a given single pass? Is that anything fixed, or you just?
For a cerclage, I would say the more you can, the better, to avoid any little gaps and little spaces. I think per quadrant, I think as you saw there, I think at least I take at least 5 or 6 bites, ideally for cerclage. And you know, again, you have to decide on how the iris tissue is. The bites are usually 0.5 millimeter from the pupil edge, although if there's an area of atrophy, I may go farther back. But that's usually what I end up doing. Now, it's a little bit different if you're doing interrupted sutures. In that case, you expect you're going to have a dog ear or you're going to have a gap, and you can go back and suture it, as Gaurav showed nicely, if there's a gap or there's an area that's existing still.
I must congratulate all the speakers for a wonderful presentation. There's one thing that many people like to know, and that is that whether this procedure can be done in phakic eyes. All these procedures that have been shown, what about to do in phakic eyes?
So it is for all of you. So like a rapid fire, you each one of you can respond. Whether you do it in phakic eyes or not. Gaurav?
So I won't do it in a phakic eye, but I have done it in a ICL eye, where we had a Urey-Zavalia syndrome. And after that, we had a, iris, which was, floppy and it was dilated. So I've done it on a, eye with an ICL inside, but because that's kind of like a protection. So, but I wouldn't do it in a phakic eye.
Priya, you have done? Priya?
You have to unmute yourself.
Priya, you're muted.
Sorry.
She's in the water.
Yeah. So actually, it is very tricky to do it in a phakic eye. To be frank enough, coming up to the iridodialysis and other things, we have always done it because these cases are mostly traumatic in nature, or they might be iatrogenic in nature, but at that point of time, you are probably doing a cataract surgery or you're doing an anterior segment surgery. So yes, it is very tricky to do it in a phakic eye.
Or you would agree with that?
Dr. Amar?
Yeah, I would prefer to do it in a pseudo-phakic eye, but I think Mahipal is got a great trick also to do it in a phakic eye. But saying that, one sentence I want to say, a couple of things I want to mention here is, I had the great chance to meet McCannell, the guy who first started this whole thing. And I was in Minneapolis with Dick Lenstorm's group once, and I met him. And I asked him a question at the time, that how do you get this idea? He said, I suddenly had a 16-year-old child, and he was phakic, and he just decided to pass a needle and did the first McCannell suturing, which is a great man he is. Also, I want to tell Gaurav later on, can you please share the screen to show the OPL also? Mahipal, can you tell us your trick for it?
Yeah, so basically this was a patient I have done that actually twice. One was in a patient of ICL where we used to do at that particular time a peripheral iridectomy, and the peripheral iridectomy became a complete iridectomy. So for that particular case, we had a support of the ICL as Gaurav had. But this was another case who was a post-traumatic sphincteric atrophy of the pupil, and the pupil was dilated and he was having terrible problems at that. So instead of making him, otherwise there wasn't any dialysis, etc. So instead of making him a phakic, what we did was that we put an equivalent of the Indian ICL, which is the IPCL in the eye, did the 4-pass and did not tie the suture fully, and took out the IPCL and then tied the sutures. So you had the support of the IPCL or an equivalent or an ICL when you were passing the sutures. So under those circumstances, the lens was saved and there was no problem. The patient is doing pretty well. So that's the trick that you can have. Obviously, you will be sacrificing the lens that you are using, but apart from that, there is nothing. So you can use any power IPCL, that's not a problem. So you just put it in and take it out. It's very easy to put it in and take it out. But use that as a scaffold. It's more like what Amar described as an IOL scaffold. So you have an IPCL scaffold for passing the suture, and before tying it, remove the IPCL.
So I'll just answer very quickly. We've had a lot of experience, actually, believe it or not, in phakic eyes. I know it's not the first place to look at, but we've done a large series. By large, I mean about 25 plus patients. And I think it can be done. It's just a matter of really the proper technique. I wouldn't do a cerclage, mind you, but multiple sutures or a small defect or coloboma can be done. We always warn patients about the risk for cataract, and you have to be in and out pretty quickly. I mean, the longer the eye is open, without even touching the lens, the longer the risk is for damage to the lens. So it can be done. I would have the usual warnings, though, of course.
This is for Dr. Vasavada, sir. If there's a patient who has an iris coloboma and also has an iridofundal coloboma, then what would you suggest in those cases?
Actually, until Amar taught me this, I used to do the segmental implantation in the back of these colobomas, which will cover the area and works very well.
So now you would, anybody who would want to differ from this? you would still go ahead doing a pupilloplasty for these cases?
Yeah, we are doing
If there's a
pupilloplasty.
fundal coloboma, even if there's a fundal
Oh yeah,
coloboma?
even with the fundus coloboma, because we close that iris defect a little bit, which helps the patients a lot.
Vish, there's a question for you. They're asking, can this prosthesis be used for albinism?
Sure, I don't see why not. I think, again, you got to be careful with the capsule integrity when you're doing that, but sure. And this is something you don't, you would not put this passively in the sulcus in a phakic patient. This is something you definitely need to remove the lens when you're doing this.
And why would you want to avoid Hoffman's pocket, as mentioned by Dr. Mish and Dr. IK both?
I'll answer that, because when you have a knot under, even if it's a deep Hoffman pocket, when you have the knot under the sclera, they're very high risk for eroding superficially through that. And then patching that can be a real exercise in frustration. Putting in a avascular scleral patch over that or tutoplast, eventually the knot will typically erode through that as well. So you have to be very careful with that.
Okay, so this is for Dr. Suhas Saldipurkar. In pseudo exfoliation, if there's a case of pseudo exfoliation, do you think the iris will behave a little differently? How would you handle that? And also, second condition is when you have iris depigmentation and it's kind of friable iris. So, would you want to do? What do you want to do these procedures in those cases? Unmute.
Mute.
Well, with regards to pseudo exfoliation, there should not be any problem dealing with the pupil, because pupil is going to be working okay. On the contrary, it will be a little smaller than normal at the end. And what was the second situation you said?
The second was when you have a trauma and the iris kind of gets depigmented, becomes friable, then becomes difficult to handle also.
I know if the defect at that stage is not too much, I would probably just leave it like that. But then I have the experience of handling such friable iris for suturing in the past, but I obviously would not try a pupilloplasty of the kind that we do today, where we really get to bring it very small. But you can always take a suture in the periphery just to kind of get the area smaller. But it's difficult. But I have had I've tried in the past when the defect was larger with the Indian make of those those segments. But somehow the experience wasn't really good, so I have just given it up.
So there is a question for anybody to answer: how frequently iris repair done in status post-acute angular glaucoma with very shallow AC?
I have done it in the past where very high pressure and the pupil was all stuck and the angle was closed. But I haven't been able to achieve the kind of results that Amar has, although the pressure has come down. But over a period, a tightly taken suture sometimes gives way. But Amar, I must tell you, the pressure does tend to stay low. That's a great thing.
There's one question regarding children. Whether these procedures can be done in children and at what age you would like to do any cutoff or for any specific procedure. Dr. Amar?
Yeah, I'm doing it in young children also. I want to also tell you, once I had a patient who flew down from Canada for pupilloplasty for me, and the patient had some iris tumor. And when I saw the pupil, it was pretty good, but they were having a recurrent problem. So I asked, who was the surgeon who operated you? The iris thing was looking so good, and it was Ike Ahmed. I said, go to hell. I said, what this guy is doing? He's magic fingers he had, and believe it or not, the patient was phakic. It was a 9-10-year-old child, and I got a heart attack seeing it, and I said, listen, I'm never going to do live surgery next to Ike.
I think, Rajesh, you also have experience of doing it in children. Would you enumerate?
Yeah, I've done it quite a lot in children. I've combined it with the endothelial keratoplasties, wherein I have to do these are single chambers when I do these glue dial techniques and then combine these pupilloplasties. So it works very well, and it is really very useful to have a good tamponade. If you good a nice pupilloplasty, so the air tamponade is very good, and the results are quite good. A couple of scenarios wherein I found it a bit difficult, that when there is partial iris atrophy, and then in that case, even if the edges, they align very well, but the point from where the suture is pulling the iris develops a small hole kind of thing.
Oh,
So
yes.
these things, any tip for that, Dr. Amar?
I'm not, if it's small defect, I don't think it'll make too much of a difference. Otherwise, you can always suture up that defect. One thing, since you brought up this intrascleral haptic fixation, whether you're doing glued or Yamane, one problem you can get is an optic capture. So a simple trick which I tell people is just put in air at the end of the procedure. We do glue dial. If by chance I get an immediate optic capture on spot, you understand, I repeat the question sentence again, I'll put in air. If I get an optic capture with air inside the eye, immediately I'll take out the air, do my pupilloplasty 4th row, so that my optic capture will never occur post-operatively. So as you said correctly, so small children, I'm very much comfortable in doing it. Age is not a criteria at all when we are doing pupilloplasty. So we are doing it at any age.
IK, this one is for you. What about visual fields in cases where you've done this?
So we know that visual fields, once you start getting down to less than 3 millimeters, can impact the reliability of visual fields. That being said, again, it's quite variable patient to patient. So you might get some impact, yes, for a very small pupil, like the pinhole pupil size. But again, from my experience, when I'm doing typically these pupils, they're not usually smaller than 3.5. So the impact is minimal. But yes, if it's very small, if it's going to be a 1 millimeter pupil, then no doubt there's going to be an impact on the peripheral vision and visual field.
But typically, Amar, when you call it as pinhole pupilloplasty, what is the size of the pupil?
1.5 to 2 millimeters.
So as IK is saying that fields will get...
yeah, we have tested that on our fields with 1.5 to 2 millimeters. We have published it also. Our fields are not affected at all with 1.5 2 millimeters. What can happen is the illumination in the room sometimes can come down. That is, a person, if you make it too small and the person is uncomfortable. So that's why what we decided was with Jack Holiday, we made different pupil apertures. Before pre-operatively, we show them 1.5 millimeter, 2 millimeter, 2.5. We ask them what are they comfortable with. Depending on what they are comfortable with, then we decide on the size of the pupil and we make it. So more than the field effect, I think is the illumination, which slightly would come down if you make it too small. So don't make it too small.
No, but typically ever since our postgraduate days when we were on pilocarping, we said reliability of the fields are not good.
Correct.
Yeah, that is true. I mean, there is some impact. There's no doubt there's some impact. The question is how clinically significant is it?
Correct.
And so I think that I would agree. I don't think it's that significant, but technically, yeah, no question. Once you get down to 2.5, 2 millimeter size pupils, there's an impact on the sensitivity.
Okay. Another question is that can we use nylon sutures?
You need the Prolene because they are non-biodegradable. So if you use the nylon, they are biodegradable sutures. So my suggestion to everyone is please use the Prolene sutures, and you can use 10-0 Prolene or 9-0 Prolene, whichever one you want.
Is there any preference when you would use 10-0, when you would use 9-0?
Amar, I saw many videos using 10-0, but I use 9-0 Prolene.
Yeah.
I also prefer 9-0 Prolene.
I also
prefer a 9-0.
I believe 9-0 Prolene.
Okay, so people want to know if it is okay with this much size of the pupil. Can they drive?
Oh yeah, definitely.
After getting a pupilloplasty done?
Oh, they drive very well.
Well, are you speaking about Indian drivers?
They can drive it.
I think after a pupilloplasty, the only job they can do is to drive.
Gaurav, why don't you show the OPL flyer?
Yeah, I'll just upload. We have the new program coming up.
I would just ask Dr. Vasavada to say one last word. We've been struggling so hard all these years with the lens and the cornea, and iris is something, which is relatively new. So what would be your take home message at the
I think we, the surgeons, particularly I have learned, we never paid attention to the iris repair and defects as much as these experts, Amar and Priya and Ike and Mitch have taught us over the years. So I think let's start paying attention to this, and we're looking forward for that book, Amar, that you and Priya and Ashwin are bringing up. So that's something we are looking forward. So thank you for the opportunity. I must leave now, and Thank you all for educating so well. Thank you.
And Dr. Suhas Haldipurkar, your last word
Well,
on how the iris is, coming up or has already come up.
well, every time Amar has come out with one of these, new aces, it's only made life beautiful. In fact, we all were discussing some time back about whether that person will be able to drive and this and that. Now, here are the eyes that are so desperately poor, and with pinhole pupilloplasty, when they get 6/9 and 6/12, it's like heaven for them. So some of those small defects, even if they stay, doesn't really matter because their distant visual acuity improves so well. Amar, hats off to all those things. And we also were talking about these phakic eyes and suturing. The trocar stuff, when you combine with the suturing, it makes pupilloplasty even in a phakic eye so easy. Even the trocar concept, Amar, is a beautiful one.
Thank you.
Namrata, can I show the,
please.
OPL slide quickly, and then we can, go on with the. I'll quickly show this because this is one of our, very big programs. So Dr. Amar is planned out this amazing international OPL for the first time. It's going to be on the internet, and everybody around the world is going to be sitting at their homes and doing this unique OPL. And we have a great lineup of international speakers. It's of course chaired by Professor Amar Agarwal and Namrata. And we have Dr. William Fishkind, who's these are the panelists below there, Dr. Benny Jeng, Ron Kruger, Dr. Lalit Verma, Ron Yo, Dr. Rajesh Sinha, Partha, Dr. Lahane. And then we have 4 teams from across the world. And this is happening on the April 28th, 6:30 p.m. India time. And these are the 4 teams. So we will have an amazing lineup, Dr. Rohit Prakash, Dr. Jagat Ram, Dr. Ragini Parekh, Dr. Eric Donenfeld, and we just look at the amazing topics we are covering. So each person is covering a pre-assigned topic, which is going to be fantastic education. We have on the Yamane technique, Dr. Brian Kim, Dr. Mohan Rajan, Dr. D. Nuano, and then we have Dr. John Hart, Dr. Priya Naran, Dr. Mahipal Sachdev, Dr. Kevin Miller, Dr. Susan Jacob, Dr. Haldipurkar, Dr. Mitchell Patrick, and then Dr. Namrata presenting. So we have a galaxy of lineup. This is going to happen at 6:30 p.m. on April 28th India time and across the world. And of course, we have to keep the audience involved. We are going to have an online poll for the audience for the best team. So we will have the web people have set up a polling system for the best team, for the most innovative video, for the best educational video, and of course for the best headgear, to make it fun like OPL always is. So I think the only one who's going to have a little bit of a problem coming with the most amazing headgear is our president himself. But I'm sure he's going to innovate as always. And everybody else, of course, please come with your unique headgear. And we'll miss Aiki, who has a natural nice headgear as well. And
good luck. Good luck.
April 28th, please do log in and block your day, save your dates. Thanks, Namrata, for allowing me to pull that out.
So I think we conclude this webinar. I would like to thank all the people who were a part of it and all the international faculty that we had, all the speakers, Amar, Priya, Ashwin, Gaurav, Dr. IK, Dr. Mitchell, and Dr. Suhas Haldipurkar, Dr. Vasavada, who were our eminent panelists. Then I would like to thank AIOS President, Dr. Mahipal Sachdev, and the Treasurer, Dr. Rajesh Sinha, again for being a part of it and getting it through. We are grateful to Johnson & Johnson, Mr. Jasminder and Mr. Gaurav for their support at the back end, and Kripal, Rakhi and Mr. Bhageshwar from the AIOS office. We were on YouTube, Facebook, as well as on the web. And we have this exciting webinar which is coming on the 28th, and on the 29th, we have yet another webinar, and that is International COVID webinar, where we've got international experts from all over the globe, which includes Japan, Dr. Kinoshita, Dr. Jodhbir Mehta from Singapore, Dr. Shudosh from US, and all over the globe. There'll be about 9 international experts from 9 countries who would be talking about COVID, how they are facing it and how they're going to come out of it, because all of us are on various stages of, COVID. Somebody's come out of it and we are still into it. So we'll be discussing that. So stay home, stay healthy, stay safe, and you keep watching. Thank you so much.
Thank you very much, Namrata, for all you're doing.
Thank you.
Thank you very much,
Thank you, everyone.
everybody.
Thank you.
Thanks, Aiki.
Thank you.
Special
Bye.
thanks to Ike and Mitch who've made it all this way.
Yeah, at such odd times.